Hello and welcome to The Resilient Investor with me, David Stevenson. As with all episodes of this podcast, we try and take a kind of big subject and try and simplify it for investors, and also to try and give some clues to investors about how they can navigate through kind of volatile markets. And we're gonna return to a subject which we've sort of circled around quite a few times actually, which is the whole healthcare sector. And I've got Paul Major with me from the Bellevue Healthcare Trust. Paul is my go-to expert talking about healthcare, and we're going to talk about two or three subjects which are sort of generally in the news and particularly in the news at the moment. GLP-1s, the whole kind of obesity drugs industry, and what's going to happen next in it, because that seems to be a huge area. I mean, literally every week seems to be some story about GLP or anti-obesity drugs being able to cure X. So that seems to be a huge story. We thought we'd talk a little bit about the whole health economics problem. By the health economics problem, I simply mean that pretty much every healthcare system in the world has got a problem with efficiency and spending more money, and arguably getting less for it, which is probably more an NHS problem. But the whole kind of like the spiraling cost of healthcare and what that means from a general investment perspective. And there's got lots of implications sort of echoing through society. And then because we do try and keep some contemporary echoes in there, we've got to talk a little bit about the rise of RFK Jr. in America. Paul, welcome.
Thank you.
Let's start off with GLP-1s and the anti-obesity drugs. I mean, do you think? I mean, they do seem to be a real game changer. They do seem to be having an enormous impact. If nothing else, people seem to be spending endlessly more amounts of money on them. I mean, literally, as we recorded this week, one of the big private healthcare companies, Vitality in the UK, announced that you could now get the can't remember which one is. I can't remember the name. Semaglutide. I'm terrible with names.
Semaglutide, yeah.
Semaglutide and Wegovy. Is it Wegovy?
Wegovy, exactly.
Wegovy, yeah. You can now get them on Vitality's healthcare plan. But the two things that seem to be interesting about Paul, which is and lots of investment implications, is that they do seem to be working or not, you may tell me, with lots of other conditions, medical ailments, and other things that trouble the health systems. Mm-hmm. And then there seems to be another generation of them coming along. So I'm guessing the GLP-1, the clue's in the title, one. So I'm guessing there are next generation things. And where do you think these next generation treatments, and because we're hearing about, I think these ones at the moment you have to inject them, Nigel, don't you? We're hearing
That's
about
right, yes.
Hearing about tablets and all sorts in the end. You only have to take them. I think the existing ones you have to take every week. Is that right? Injection? You may correct me, but you might have to you do it every month. Where do you think it's going, and how all pervasive do you think these anti-obesity drugs will be in terms of the things they treat?
Sure. Let's take a step back for a second and just talk about something that covers the first two topics that you mentioned. If we look at society today, we live in a it's an overused phrase, but this idea of an obesogenic environment. We're surrounded by easily accessible, calorie-rich foods. There are lots and lots of labor-saving devices. So people generally eat more calories than they ever have done in history, and they move less than they used to, which is a combination for weight gain. Now, we all understand, I think, fairly simply that if you ingest too much fat, it eventually clogs your arteries and ends up in the wrong places, and this can increase your risk of cardiovascular disease, which can lead to obviously death and serious disease. And then there's also a more complicated thing, which we won't go into in too much detail, but basically fat is pro-inflammatory. So the more fat you have, the more likely you are to be in an inflammatory state. The more likely you are to be in an inflammatory state, the more likely you are to damage bits of your body through your immune system working incorrectly, so basically attacking itself. And also it triggers cancer-like effects. So being fat generally is bad. And then you think about secondary complications. You put much more stress on your body, you put much more stress on your joints and all these sorts of things if you are obese. So we have to differentiate between primary consequences of obesity, which are predominantly macro-cardiovascular and a bit of cancer, and then secondary complications. So, for example, if you have osteoarthritis and swelling and inflammation in your joints, and then you take an anti-obesity medication and you lose weight, you reduce the pressure on your joints, so your symptoms of your arthritis will ease, but you haven't treated your arthritis. So there are lots and lots of trials going on, as you say, and they're demonstrating two things. The first is that disease is worsened by being overweight. Symptomatology is improved by losing weight. That's not miraculous. That's an obvious thing. But these are the first really effective weight loss drugs we've had in a very long time. And so you can prove all sorts of wonderful things in clinical trials. That having been said, if you look at some of the secondary metabolic and cardiovascular effects of these drugs. There's a phrase that we use in medicine where we talk about pleiotropic effects. So some things have unexpected benefits which are beyond the primary mechanism for which you took them. Statins are a great example of a drug with significant pleiotropic effects. It seems to be that these GLP-1 drugs have secondary metabolic effects which are highly beneficial and go beyond their intended role. So, for example, they seem to be anti-inflammatory in and of themselves. So GLP-1, is it a wonder drug? No, I don't think there's such a thing as a wonder drug, but certainly they are proving to be better medicines than was previously imagined when they were first conceived. We do still have, I think, a couple of significant challenges, and there are some interesting papers around all of these things if people want to search the medical literature. The first is these are not really good drugs to take for a long period of time, because there is.
And that's actually just to interrupt you, because I was going to ask whether or not you think that GLP-1s will end up a bit like statins, which is, people treat statins almost now as though they treat just popping, a couple of paracetamols, and they can do it for a long, long period of time. Doesn't seem to be any long-term major implications for most people. And you literally hear doctors go, "Oh well, you may as well do some statins because it's all right for you." They're not in that category.
Not quite. So again, let's take a very simplistic starting point for all of this. So your body is constantly turning over and renewing itself, and that's why you have to constantly ingest nutrients, because your body needs them. Now, the primary way these drugs work is they suppress appetite. You stop eating. You eat less food. You drink less alcohol. You do less of most things, actually, if you're on GLP-1, and that isn't necessarily good. So, for example, in an obese person, you're probably losing 25 or 30% of the mass that you're losing is healthy tissue, not fat. Now, the higher that number goes, the worse it is.
And we're talking muscle there, aren't we?
We're talking muscle. We're talking, you're going to lose a bit of fluid volume, blood volume, but we're talking muscle, we're talking bone, we're talking ligaments, we're talking important stuff. Mostly muscle is a big thing, particularly for more elderly people and particularly for women. It's very, very difficult to regain muscle mass as you get older, and much harder for women than for men. So the idea of being on these drugs for a protracted period of time is not really a good one. If you're targeting a certain amount of weight loss because you're obese, you should go down to that weight loss, and then you should seek to have some kind of weight maintenance therapy. Is that a low dose of GLP-1, or is it some other weight loss mechanism? Now, central to this, there are 4 or 5 different hormone systems that interact to control appetite, a deposition of muscle and tissue, and all these sorts of things. And there's a lot of excitement around a molecule called amylin, which again, we've got data on this going back decades. Amylin, particularly when combined with GLP-1, seems to lead to much better ratios of fat loss to muscle loss. So
that means you lose more weight or fat, but you lose less muscle.
Yes, I think the second bit's more important. Some people imagine combination treatments are let's just lose even more weight even more quickly. I think if you're a doctor, what you're saying is let's make sure the weight that we lose is in a safe, controlled manner at a rate that is livable with, and minimizes the lean tissue, the healthy stuff being lost. So that's definitely the direction that a lot of people are going in, looking at combination therapies. The second challenge is one you've alluded to. Demand for these drugs is more than anyone can basically supply, and the fact they're injectable syringes, wasteful, need to be refrigerated, etc., etc. If you could do this with pills, it would be better. So Lilly is going to be the first one out of the gate with an oral GLP-1 analog. We should have data later this year that tells us whether or not this is a genuine alternative to injection. I think, to be honest with you, no one's even thought about the potential value of the weight maintenance sector. Everyone who's ever been on a GLP-1 and lost weight, that is a potentially a big segment. And you have to do this because if you look at what the data tells you, if you were overweight, you went on a GLP-1 for 12 or 18 months and you lost weight, you got down to your target weight and you stopped taking it, all the data shows you that you would regain 60-70% of the weight you lost within 6 to 9 months. And worse, you would gain most of it back as fat, even though some of what you lost was muscle.
Yeah.
So if you think about body composition, you end up in a worse place after this than where you started. So the whole yo-yo dieting kind of nightmare. So we definitely need weight maintenance drugs. And I think that is going to be a very sizable market dominated by oral therapies. There's lots of people in the race. Lilly is in there. Novo is a bit behind them, but there are lots of other companies who have thought very hard about tolerability and about scalability of manufacturing.
So what we're talking about here maybe is a combination of maybe lower doses with easier ways of taking the medication.
Exactly. A gentler therapy that's designed to let you have more food choices, so not be in the situation where you don't fancy eating, because that does have impacts around sociability. You have to accept that our society is based around eating and drinking fundamentally. So if you're the person, every time your friends phone up and say, do you want to come for a drink, do you want to come for food, and you always say no because you're on GLP-1 and it doesn't immediately occur to you that's something you want to do, eventually the phone stops ringing. So there's a whole second order kind of lifestyle mental well-being aspect to getting people onto a therapy that's a bit gentler, helps them stay at a healthy weight, but also go back to living the life that they want and doing the things that they want to do.
Do we think that, these drugs and the companies that make them are absolutely structural to many stock markets? So, I think Novo Nordisk, I think it's the most valuable company in Denmark by a long way. Mm-hmm. And I think if you look at some of the figures, it's probably one of the most successful stocks in the European stock market. Eli Lilly's been a very successful US stock. A lot of these really make a difference. Do you think it's the big guys that are going to get there first, or is it going to be the scrappy biotech firms who are busily, working with new treatments? Who do you think? None of us know because they're all deep in trials. But who would you? What's your hunch? Who will get there first?
Well, again, this is a really interesting debate. I think there are two questions really there. The first is, where are the molecules going to come from? And there I think lots of scrappy biotechs are going to do very well. But ultimately, if you live in a world where you're competing multiple companies fighting for the attention of busy GPs to talk about weight maintenance pills, which all kind of probably look very similar, at least initially, because it'll be years before you can do trials to prove one's better or more tolerable or whatever it might be, then it's going to be about marketing heft and boots on the ground, and therefore you're going to need big pharma. If you talk to any of these companies, none of them have a go-to-market strategy that doesn't involve partnering with a major pharmaceutical company. They're quite happy to do the phase 1, phase 2 trials, prove the molecule has utility, novel mechanism, etc., get the patents all done, but then they're definitely looking to either sell themselves or license the products out.
Now, this all links back to the second question, which is about health efficiency and health economics and the amount of money that all the health systems around the world, not just in the UK, we have endless stories about in the NHS about more money, less output. But that's not a new thing. You talk to economists; they talk about things like the bowel mold disease, which is endless cost inflation in things like healthcare and education as well. So it's not just healthcare, but healthcare is obviously an increasingly large component of most government spending. And again, that seems to be an irreversible trend, if nothing else irreversible, because of an aging society. So, it's not, there are other factors kicking around here, not just pure cost inflation. There is an aging society, it means more money is being spent. Are there any serious ways, and we're going to come on to RFK Jr. at the end, are there any serious ways that people can make a dent in that cost inflation for the medical industry?
Yeah, so funnily enough, not knowing what you were going to ask me, I happened to be looking at this in detail the other day. So I've got the numbers to my mind. So if you look at the WHO, who are the kind of gold-plated data set for all this stuff, we have data for the OECD that's detailed up to about 2022. So it covers the post-COVID period, because obviously COVID did send healthcare expenditure skyrocketing and then it came back down again. If you look from 2015 to 2022, over that period, global healthcare expenditure increased in the OECD, sorry, not global, in the OECD, it increased about 34%,
Right.
which meant it grew faster than GDP. So if you take the median and the average percentage of GDP spent in healthcare across the OECD group, looking at 2015 and 2022, it's 40 basis points higher. So to your well-made point, we have existed in a world for as long as I've been doing this job, which is 3 decades now, where the reality is that healthcare expenditure increases faster than the broader economy and is consuming an ever greater share of our marginal wealth.
And it's also inflation rate is increasing at higher than the underlying inflation rate. So if you have a core inflation rate, pretty much all years in health inflation number is bigger, isn't it?
Yes, and if you look at the demographics of this, they're frightening, because 80% of healthcare expenditure is chronic diseases. Of that, 80% is spent on the over 65s, who aren't as economically productive, or often no longer economically productive. We have a shrinking birth rate, so we're asking an ever smaller number of non-retirees to support an ever greater number of retirees who are spending an ever greater amount on not dying, and the less dying they do, the more healthcare they're going to require. So you end up with this very, very challenging demographic picture. So when one initially looks at that, it is a huge concern. However, if you take a step back, and this is the primary thesis for us launching this investment trust back in 2016, there are innumerable products, technologies, and services that show you that you can do things much more efficiently, or drive better outcomes or improve productivity compared to where we are or where we used to be. And just think of it again, a simple example. If I'd have said to you during the IPO of the trust, if I'd have come to you and talked about, one day you'll have an app on your phone, you'll be able to access your NHS data, book appointments, renew prescriptions, you won't need to see a doctor. If you do need to see a doctor, you'll probably have a virtual interaction via a video call on your phone before you waste the GP's time, bearing in mind 80% of GP interactions are deemed not medically necessary after they've taken place. You probably would have laughed at me. The idea that the NHS could show such competence as to develop such an application.
Digital NHS, exactly. I would have known 10 years ago.
Indeed, or that they couldn't, waste 100 billion doing it. But the reality is, this is normality. Now, not everybody likes this, but we've gone from a world where the front door of the NHS was permanently jammed open. You could stroll through it of your own volition, waste as many people's time and money as you chose. Now, there's a digital gatekeeper phase in there. It does make things like prescriptions and other things easier. And then you take it to the next level. The NHS is putting more and more clinics for routine things like weight measurement, blood pressure measurement, these kind of routine things in leisure centres, in community centres, in branches of Boots. My GP surgery's just put an electronic blood pressure machine in the reception. So apparently you can go in, you put in your date of birth and your name, and it tells you what to do, and then you don't actually go into the GP surgery if you're required to do blood pressure reading. So there's lots and lots of ways you can see these are very simple things that start to improve productivity. So we're actually very optimistic on a multi-decade view that productivity can improve hugely. Part of that is driven by exciting and interesting technologies, but the other part of it is what you alluded to earlier, which is we're coming from a base where the stats are terrible. So if you look globally, it's generally accepted $1 in $4 spent in healthcare is wasted to no medical benefit whatever.
1 in 4.
1 in 4. 1 in 5 interactions is probably not necessary. People spend enormous amounts of time in hospital longer than they should do. Many people don't need to be in hospital; they could be treated remotely or at home. If you think about your experiences of going to for a simple surgery daycare type thing in a private hospital, you're in and out in half a day.
Yeah, absolutely. Yeah.
You contrast it with the NHS. It's extremely difficult to get yourself discharged, even when you want to leave.
Absolutely, yeah.
So and this is just the problem of the size of the machine. But acuity, all these things. If we can get people treated in the right place, which often is at home, in their own under their own recognizance, we can achieve enormous cost savings and scalability.
And are the people who are going to, or the corporates are going to do that, are they the big healthcare giants? Are they more your kind of medical equipment giants, or is it going to be the tech companies? Because I mean, the tech companies are sniffing all over the healthcare sector.
Yeah,
they're all over it, aren't they?
The answer is it's everybody,
okay.
And it's different things. So firstly, you have to prove that something can work. Secondly, you then have to pull the equipment to do it yourself. But let's imagine a situation where you'd had some kind of surgery and you needed to recover at home, but you needed your blood pressure monitoring, you needed maybe your blood sugar monitoring. We needed to keep an eye on your weight. All I really need to provide you with is digital blood pressure, an iPad so we can have some FaceTime interactions, some digital scales connected to the iPad, and a few other bits of kit so that I can see that you take the medicines that I give you, maybe wear a glucose monitor. All of those things I could buy from Amazon.
Yeah.
Then and then someone needs to write a clever piece of secure software that enables them to all talk to each other via Bluetooth and then upload that data into the cloud where someone in the NHS can keep an eye on it. So it's not complicated. I think part of the challenge here is really to do with regulation. You know, we hear time and again the problems in healthcare are caused by blockages of social care. But you look at the adult social care model, 1 in 10 vacancies in 1 in 10 jobs in social care are permanently unfilled because people don't want to do them. And the whole business model is around the deployment of human labor. So the reality is you could have clever ideas to reduce the deployment of human labor and apply technology to look after old people, for care in the community, you know, Meals on Wheels, all those kind of things. The reality is you would then not be paid because you're using less human labor. So there's an element of this that is regulatory driven, that the regulators of healthcare and social care haven't kept up with the pace of technological change, and the reimbursement models don't support innovation in the way that they should. But those things can be changed quite quickly and quite easily if the will is there.
Well, talking of the will is there, that brings us to the last subject. The will might meet our RFK Jr. And he has certainly in the States, the new health secretary, or I think it's HHS, isn't it? I can't remember.
Yes, HHS, yes.
And he's certainly been talking about some of these things, hasn't he? And he although he's sort of added a kind of anti-drugs kind of thing about it, which is the American government spending far too much money on drugs, which it probably is, to be fair. But that's sent a shiver down the spines of the big pharma and biotech companies. None of us really know about it at this early stage, so we're all guessing it. What's your take on the big kind of moves around RFK Jr. And I suppose that bleeds into the whole kind of thing about cutting government spending in America, which is nothing, which is beyond just healthcare. What's your early take, and what do you think it means for investors? Because one thing investors seem to have done was that when it first happened, they sold pharma stocks and sold biotech stocks. What's your take on it?
So I'll make two general observations as a starting point. So the first is, as you rightly allude to, we are living in a stock market dynamic of shoot first, ask questions later.
Yeah,
so
exactly.
As soon as anything remotely bad happens, everybody jumps on it, assumes what the worst case scenario is, and then repositions accordingly. And RFK and comments from other people associated with the still forming Trump administration have caused some consternation. I think the second thing to recognise is we are living in the world of the soundbite and the meme and social media, and the way
podcast, by the way.
Yeah, exactly, and podcast. Yeah. Well, I mean, we've already failed. I think we've used more than our 240
words.
To say,
we've gone past our 35 seconds. And
exactly, and our 30-second attention span. We're showing our age here, I fear. So if you look at politicians who are on the rise globally, here in the UK, if you look at somebody like Nigel Farage, his gift, for want of a better word, is more effective messaging.
Yeah.
He tells people what he thinks they want to say in a way that they understand, that's very clear and concise.
Very clear, yeah.
On the other hand, our current Prime Minister, no one seems to figure out exactly what he's saying, and he takes a very long time to say very little.
Rather less skilled in the noble art of communication and persuasion.
Indeed. not a born orator.
Yeah.
So Trump is the master of this in so many ways, and it's important to bear in mind how he behaved in his first term in office. Huge promises on social media. Everything is going to be the biggest, the greatest, the most significant. Nobody's ever going to have done more of whatever it is he's going to do. When he makes these pronouncements, constant streams of things on social media. The reality, of course, when you look back at what he achieved in his time in office was very different to what he said or what he tried to claim credit for. A lot of it is very, very minor, incremental change. So let's look at the NAFTA, Canada and Mexico thing. I'm going to slap tariffs on these people. It's going to be the biggest tariffs anyone's ever seen. It's going to raise zillions of dollars and move jobs back to America. 48 hours later, he's capitulated or given them 30 days notice because they've made concessions. The net value of those concessions was tiny, economically and otherwise.
Arguably, most of them they're going to do anyway.
Exactly. So he's just looking for a win, and RFK was not dissimilar in his disastrous presidential campaign. Yeah. So let's just firstly bear in mind that all these people. They shout very loudly and carry a small stick.
I think also talk a good game is the old expression.
Well, I don't know that they do talk a good game. They talk a lot. They talk a lot of stuff, but the game rarely matches up to. It kind of reminds me of one of those press conferences before a boxing match where everyone stares at each other and says all sorts of ridiculous things about what they're going to do, and then they get in the ring and they don't last 30 seconds. That's more the analogy that springs to my mind. So then let's again take a step back and look at RFK. As you rightly alluded to, leaving the vaccine stuff to one side and conspiracy theories about this, that, and the other. You can understand if you grew up believing that the government had killed a prominent member of more than one prominent member of your family. Yeah. You're probably inclined toward
your dad and your uncle.
Yeah, you're probably inclined toward believing in conspiracy theories. But we'll leave all of his personal trauma to one side. He has made the point that there's an awful lot of junk in the American diet that other countries wouldn't allow, and that food companies are allowed to do things in America that they wouldn't be allowed to do elsewhere. Yeah. This is very true. The primary reason why we couldn't get a trade deal with the United States post-Brexit was around food standards. Yeah. There was something like 80 pesticides and herbicides that are routinely used on food products in America that are banned in the European Union. So he's not wrong in some of the things he says, and he wants more accountability around food and more education of people about the health consequences of what they do. I personally think that is to be applauded.
Yes, I agree.
And I also think that that's much more his focus. Lest we forget, the HHS controls the Food and Drug Administration, the FDA. So his desire to seize control of that entity politically and his ambitions in that area might well relate more to food and food regulation and agriculture than they do toward drugs. But the point is equally well made. As a percentage of GDP and as a percentage of healthcare costs, the Americans spend more on drugs than anyone else, and their drugs cost more. And there is this whole argument about other countries freeloading on US research. I mean, the reality is there's lots of things about America that make it the right place to do medical research. Part of it being
network effects, isn't there?
Yes, exactly. And the FDA is the most pro innovation regulator, being mirrored actually with its support for innovation, but by the new regulator that's been set up in the UK post Brexit, incidentally.
Do you think they are going to take a apocryphal chainsaw to the healthcare budgets?
The amount that gets spent, the biggest entitlement programs in the US relate to Medicaid for the poor, Medicare for the elderly, and veterans affairs. So you can't take a hatchet to federal spending without looking at these things. But then when you look at the structure of them, you could make some arguments that there are certain elements of it that are not optimized for efficiency. And actually, we think around Medicare, Medicaid, transitioning more toward value-based care payment methods, which have been proven to be much more effective, is something we've invested in. I think some of these changes might accelerate all those sorts of things. They might push some of the benefits back towards some of the states and so on. So there's some clever politicking in all of this, but we mustn't forget that Trump's voter base is generally elderly, often poor, and Medicare is the single most popular entitlement program in the United States.
I think Trump has made it very clear that he's not going to be messing around with a lot of that in Social Security.
Indeed. Well, he made that actually as a manifesto pledge in his Agenda 47 document that was published at the beginning of the election. So again, to the extent that you can rely on the man keeping his word, you're absolutely right. It doesn't suggest wholesale change. So just to summarise, my personal view is that certain sectors of the media want to talk about all the vaccine denying stuff. And all that kind of thing. I think his bark is going to be way worse than his bite. I don't think healthcare is the primary focus. I think the food industry is, and I think in the fullness of time we'll probably look back on this and say, well, it wasn't as bad as we thought. When does the stock market maybe catch up with that? I don't think it's for a while. It's probably once he has identified what his personal priorities are going to be, managing the HHS, which is a very broad organisation, and then within that, who gets appointed to head the individual important agencies.
Which is probably going to be more of an issue in the next few months anyway. So
yes,
staff and personnel at the moment, isn't it?
My personal view is that when we talk about the drug sector, the single most important thing is how confident management teams begin to feel about the antitrust outlook and M&A, because everybody needs to refill pipelines, and that has historically been how they've achieved that. And under Biden and the FTC under Lina Khan, that was much more challenging to do.
And the Republicans have long got a track record of being more tolerant of M&A activity and less interested in overzealous regulatory overreach. So that could be positive for M&A activity in the sector.
I would think so, and that's something we're expecting to pick up in the second half of the year, precisely for those reasons. So I don't think it's all doom and gloom. I think the market is one to be very binary about these things, and particularly to price the negative risk first. We will have to see, but I think America is a global leader in healthcare, and it probably recognises that's a high value added industry, and it doesn't want to give that position up easily.
No. Okay, Paul. Well, as I said, we've both shown our age because we've miserably failed the 1 minute concentration limit because we're now well for half an hour. So, but a fascinating half an hour, and I think the big takeaway is that there's actually a couple of big takeaways there, which is one, you've got to be careful, I think, not to be knee jerk. In a fear of missing out FOMO market, people do react very quickly, and sometimes I think too many investors overreact. And they overreact to, as you said, news signals, or they overreact to kind of macro signals. And sometimes actually the kind of deeper structural forces, the tectonic forces that are moving, they don't always move in the way everybody thinks they do. And they quite often move very slowly, and they just carry on moving. And I think the second thing is that we need to think, when we talk about healthcare, the sector, we need to think about the wider thing. And, one of the things we didn't mention was just a lot of the excitement around obesity drugs was building up that momentum. Food company shares were taking a hammering. So, a lot of the big American companies that sold food that is less than nutritious, shall we put it, took a hammering, and some of the supermarkets did as well. So quite often these healthcare effects ripple out to other sectors of the economy. And I think it's incumbent on investors to think through. It's not just always purely a healthcare issue. It's quite often food. It's quite often extends out to technology. The technology companies are crawling all over this space. So that's that. It's, sometimes don't be too thematic. Sometimes think about the wider consequences. Anyway, on those thoughts, Paul, thank you very much as always. I hope you've enjoyed listening to The Resilient Investor. Also, check out the Bellevue Healthcare Trust. They are experts in this. And in the meantime, happy investing. Bye-bye.
Thank you.